Well, a little bit unusual situation where you have to overlap BRS. Now, certain situations where you have to think of overlapping a BRS is especially when you have a long lesion, when you have diffuse lesions, or especially for arteries tapering. These are the situations where you think of overlapping the BRS. This is an elderly man of 64 years, chronic stable angina with a PMT positive at stage 2, no RWMA, good LV systolic function. There's a proximal to mid LAD 90% lesion. Plan was to go for an imaging guided PCI. In fact, this is what the angio pictures look like. You can see this is quite a long lesion starting from just after the ostium to almost 50% of the LAD is totally diffusely diseased. So while choosing a BRS, in this case, the option would be that we do not get such a long BRS. So one would think of choosing overlap the BRS. Now, the strategy is to wire the LAD, pre-dilate, pre-evaluate an OCT. I personally feel that pre-evaluation OCT is very, very important. Then overlap with the BRS, then post-dilate it and optimize with the OCT guidance. Now, this is the first this thing that is the evaluation OCT. In fact, let me go to the next figure so that in the interest of time. So if you see this was just, we had to dilate it initially because the OCT catheter wouldn't pass. And after dilatation, small balloon, we can see that this is a tightly distinct stenosis with some amount of fibrosis, some amount of calcium and parts also. So that was reason that this patient needed a good preparation of the bed. So the bed was prepared, and after the bed preparation was done, you can see how the lesion looks like. There has been a lot of dissection everywhere. You can see this clearly shows that the bed is very well prepared, and this is extremely essential when you're trying to put in a BRS so that it will be well opposed and the results are good. Then something very important to know over here is there is a triaxial markers at both end of the scaffold, and the extra scaffold level beyond this marker is 1.2 millimeter, and the balloon overlapping is 0.1 millimeter. So you have 1.3 millimeter to work on. And here is importance while overlapping to BRS, one has to be careful and has to know all about this anatomy or the device, how it differs from the BVS. Now, this is what we did. The first BRS was given, and you can see the two markers, the balloon markers, and they try triple marker over here. So this is something which is very important. The first was the 2.75 into 32 BRS, and this is very important that we should always avoid overlapping the scaffolds. This is something different from the BVS. What I call the TTT, the tip-to-tip deployment of MIRAS is very important. Align the distal balloon marker of the undeployed scaffold with the proximal arrow marker of the deployed scaffold. So supposing this is the distal deployed MIRAS, then you take the proximal and just see that your balloon marker is just near the triple marker. And this is what happens after you do that. You will see that the proximal deployed MIRAS is there, and there is absolutely no overlap. It is just a simple hugging that they do. There's no overlap, and almost it seems as if there's one device which is all throughout. It is exactly like this, that you just have to just not overlap. You have to just see that they touch each other. And this is the most important step, and you have to be very careful, see orthogonal views and then do it. So this is what we did. We took the balloon and we tried to do this tip-to-tip deployment, and you can see over here that this is the first that is BRS that is put. This is a balloon marker which you have to put just very close to the triple marker. And here you can see very carefully after the two have been deployed, you can see how the triple markers look. Unlike the BVS, where you can clearly take the marker and overlap it, this is something very different. And this is where you have to be very careful while overlapping this BRS, or when you're trying to put two BRS in a single artery. Now, this is finally the post dilatation done with the lineage 3.25 into 10 to high atmospheres. And this is what is very important, that you just see the OCT, which clearly shows that there is absolutely no overlap. There is just a hugging of the two devices. So this gives a good idea that this device is something different from the BVS that we used to use earlier, where we could easily overlap. The margin of error was very less, but here you have to see in orthogonal views and try to see that you do not overlap the device. This is the very important message that I have to give while using this thing double BRS in a single artery. Now, this is just to analyze what was seen. It was very well opposed, well expanded, and in fact, there was no overlap at any stage, and it clearly looked like a single tube. And the two devices are put in such a way that you cannot see that there is any gap also in between them. So this is just the pre and the post results. You can see it's very fine little compromise of one of the diagonals, which was acceptable. And the patient, this was done in April last year. So already a 6 months follow-up has been done, and the patient is doing well. So what is the take-home message? Number one, the TTT, what I call the tip-to-tip deployment of BRS enhances zero overlapping. Now, why this tip-to-tip deployment is necessary? Because it reduces delayed healing. What happens when you start overlapping two BRS? Then the healing is not as good as has been proposed in this BRS. This is different from the previous implantation. And lastly, OCT plays a very important role, and it's an ideal way to optimize the device. So I prefer to do a pre-PCI, a post-bed preparation OCT, a post-implantation OCT, and a post-optimization OCT. So I usually take 4 runs to be very sure that the device has been put properly and has been optimized. And this is the right way to do BRS in diffuse disease, a long segment where you have to take 2 devices and finish your procedure. Thank you very much for the patient.